Thank you, GKN sir, seniors and organizers for this opportunity. Today I would like to discuss about cytomegalovirus infection in post-renal transplant patients. So in this talk, I'll be talking briefly about the CMV virus, clinical features, diagnosis, management, CMV resistance, prevention. Before going to the talk, a short MCQ. Which one of the following statements regarding prevention of CMV infection and disease is false? General prophylaxis is found to reduce the incidence of both CMV disease and CMV-associated mortality in high-risk patients, that is D plus R minus. Preemptive therapy in high-risk patients did not have any effect on CMV-associated mortality. Preemptive therapy with viral load monitoring with valganciclovir in moderate and lower-risk patients is effective in CMV infection. Impact study showed that daily oral valganciclovir prophylaxis for 200 days provided a significant reduction in the incidence of CMV disease compared with the 100-day prophylaxis in high-risk patients. Full doses of ganciclovir or valganciclovir should be administered to have the maximum effect irrespective of renal function. Coming to a short introduction to CMV, it's a beta herpes virus that replicates only in human cells. It has a DNA core surrounded by the capsid, which is surrounded by a tegumen layer, and which is further surrounded by glycoprotein covering. The most antigenic is the glycoprotein cover, or the GB. And it has a double-stranded linear DNA virus, and it has the largest genome of the herpes viruses. The presence of virus was first suspected in 1932 when a series of cases of generalized cytomegalic inclusion disease was found in certain congenital syndromic infections. They had petechiae, hepatosplenomegaly, and intracerebral calcifications. And later in 1950s, when they were looking at cases for toxoplasmosis, both present similarly, they identified an organism which was later named as cytomegalovirus. So it was initially found by Thomas Weller in 1957. Epidemiology, around 15% of the global human population suffers from CMV infection. The CMV seroprevalence is 70 to 90% in the adult human population. And in various solid organ transplants, the maximum incidence of CMV is for heart transplants, followed by lung, and the least is for liver. Kidney transplant has intermediate risk of CMV incidence. The virus gets transmitted through various body fluids, through sexual contact, close contact, body or blood or tissue exposure, and through occupational exposure, especially daycare centers, and through perinatal exposure. So the timeline of CMV post-renal transplant is it usually happens in the first 2 to 6 months without prophylaxis, or it can happen late after 6 months, and it can present as CMV colitis or CMV retinitis. And CMV has been reported as early as 10 days post-renal transplant. Average of 60% of renal transplant recipients develop active infection and 20% develop symptomatic disease. CMV infection, it can be a primary CMV infection or a CMV reactivation. Primary CMV infection is the occurrence of CMV viremia in a previously unexposed transplant recipient. CMV reactivation is evidence of CMV replication in a previously seropositive patient. And this can be termed as a CMV disease when there are attributable symptoms, which can be either a viral syndrome or a tissue invasive disease. The post-transplant CMV disease can occur due to transmission from a transplanted organ or reactivation of latent infection or primary infection in a seronegative transplant patient, or it could be a superinfection with another strain. Coming to pathophysiology, it's a lytic virus that causes a cytopathic effect. To review again, this is structure. This is the outer glycoprotein complex, and inside there is a nucleocapsid layer, and in between these two there is a inner tegument layer. So during the initial infection, it infects the salivary gland. It can persist there and continue to shed the virus. And if it is through a genitourinary system, it can lead to clinically inconsequential viruria. Now, the replication of CMV DNA and morphogenesis of the virion capsid takes place in the nucleus. The viral DNA containing capsids acquire an inner layer of tegument proteins during their egress from the nucleus. And when it is after the egress, when it is transported along the cytoskeleton, the particle gets enveloped. Most neutralizing antibodies are directed against an enveloped glycoprotein GB, the outermost layer, and the proteins of the tegument like PP150, PP28, and PP65 can also evoke a strong and durable antibody response. So when there is a primary CMV infection in immunocompetent people, it results in mononucleosis like picture, and in immunocompromised, it could be subclinical or asymptomatic. So after the primary infection, the innate immunity is activated, and later leads to activation of T cells, NK cells, and later adaptive immunity. Later B cells are activated. So when after the body gets immune, the virus infection turns into a latent state, and the virus resides in the myeloid progenitor cells, or in the monocytes, or in the endothelial cells, and it stays as such. And when there is a reactivation in the event of immunosuppression, it can cause a secondary symptomatic disease. So the reactivation leads to releasing new virions, which infect new cells, causing CMV end-organ infection. What are the risk factors for CMV infection? The most important risk factor is a donor CMV seropositive status and a recipient CMV seronegative status, that is D plus R minus. And when the blood products from seropositive donors are received, it is another risk factor. Or exposure to lymphocyte depleting agents and acute rejection episodes when there is severe the patient is further immunosuppressed, or during sepsis or prolonged surgery, and in the presence of comorbid illnesses, neutropenia, and exposure to antimetabolites. The serology status is important for risk stratification. In the highest risk is for D plus and R minus, and when intermediate risk is for recipient positive status, and the lowest risk is for donor negative and recipient negative status. So CMV D plus R minus patients are at higher risk of developing CMV disease than CMV R plus patients. Coming to CMV infection versus disease, CMV infection refers to virus isolation or detection of viral proteins or antigens or nucleic acid in any body fluid or tissue specimen, regardless of symptoms or signs. CMV disease refers to evidence of CMV infection with attributable symptoms or signs, which can be manifested as a viral syndrome or a tissue invasive disease. Viral syndrome can be in the form of mononucleosis like picture, where a patient can have fever, malaise, leukopenia, neutropenia, atypical lymphomatosis, hepatosplenomegaly, and thrombocytopenia. And tissue invasive disease can in the form of GI disease, nephritis, or lung involvement, retinal involvement, etc. So in the presence of an active infection, the effects can be divided as direct and indirect. The indirect effects are because of immunomodulation, where the host immunity is altered. The direct effects can be because of viremia or tissue inversion. Viremia, as told, can cause mononucleosis like clinical picture. Tissue invasion can result in hepatitis, pneumonitis, colitis, carditis, nephritis, pancreatitis, retinitis, and sometimes meningoencephalitis also. And indirect effect can lead to graft rejection, graft dysfunction, and susceptibility to opportunistic infections, decreased graft and patient survival, new onset diabetes after transplant, cardiovascular events, and interaction with other herpes virus resulting in PTLD. The clinical manifestations of tissue invasive disease depends on the organ. The most common is gastrointestinal disease. In nephritis, there is renal dysfunction in the presence of microbiologic and histological features of CMV infection in a kidney biopsy specimen. GI manifestations can be as enteritis or colitis. Patient can present with diarrhea, fever, abdominal pain, and endoscopy can show well-demarcated ulcerations, ulcero-infiltrative changes, or pseudomembrane formation. Pathological examination will show inflammatory colitis with inclusions. There can be transaminitis. Elevation of ALP and bilirubin is less typical. It can cause portal vein thrombosis and granulomatous hepatitis rarely. And patient can also present with pancreatitis. In CMV retinitis, which usually presents in later periods, there can be retinal edema or hemorrhage with one or more discrete foci of retinal edema or necrosis, retinal hemorrhage, or inflammatory sheathing of retinal vessels. Neurological manifestations can be in the form of meningoencephalitis or GBS, and pneumonitis can be there, and they can present with dyspnea, and radiograph can show pulmonary infiltrates. Cardiovascular manifestations are in the form of pericarditis, myocarditis, atherosclerosis, or venous thrombosis. The diagnosis is the basis of history, clinical presentation, and laboratory data. Because CMV produces lifelong latent infection, distinguishing active disease from latent infection and asymptomatic reactivation is difficult. In immunocompetent people, the serological studies, which can either the detection of IgM, CMV antibody, or a fourfold increase in the IgG antibody can imply an infection, acute infection. The presence of CMV DNA combined with the absence of CMV IgG can also imply an acute CMV infection. So in general, the modalities for diagnosis are serology, quantitative PCR, PP65 antigenemia, blood culture, and histopathology. The molecular amplification methods, the PCR, are now the standard of care. Coming to serology, it provides an indirect evidence of recent or prior CMV infection based on antibody titers. It has no role in diagnosing CMV disease in immunocompromised patients. It also helps in risk stratification prior to renal transplant. And the IgM antibodies are usually detectable within 2 weeks, but persist for 4 to 6 months. IgG antibodies are detectable after 2 to 3 weeks, but can persist for lifelong. Coming to the molecular assay or the PCR test, they are used for monitoring patients at risk for CMV disease, or diagnosing an active CMV disease, or for monitoring response of therapy. One thing to be noted is that with various labs, this PCR assay, there is a large variability. And so for a particular patient, a single viral test in a particular lab should be followed. The ideal cutoff for a diagnosis of an active CMV disease is not established. And when in general, when the copies are more than 5,000 copies per ml, it can diagnose a CMV disease with a sensitivity of 86% and a specificity of 87%. And almost all patients with more than 20,000 copies will have a CMV disease. The rate of increase can also be used to predict patients who are at risk of CMV disease. CMV PP65 antigenemia test was used previously for detection of CMV infection, where fluorescent labeled monoclonal antibodies specific to PP65 antigen protein of CMV was used to identify CMV infected leukocytes. But now PCR is preferred over PP65 because of better assay standardization, increased stability of the specimen, and smaller specimen value, and ability to test patients with leukopenia. And culture can also be used when there is a strong clinical suspicion and other investigations are inconclusive. And the human fibroblast cultures are used for CMV isolation. It can be done from blood, CSF, throat washing, bowel fluid, urine, and biopsy specimens. And at present, when culture is needed, a cell vial culture technique is used, where which is rapid, and with the help of centrifugation and antibody, the CMV virus can be detected earlier. And in histopathology, the characteristic features are cytopathic changes, inclusion bodies, and further IHC test can be done to confirm the presence of CMV antigen. The virus has a predilection to tubular epithelial cells and to endothelial cells. The typical appearance is an enlarged nuclei with a central round inclusion body surrounded by a circumferential halo, or the owl-eye appearance. homogeneous, smudgy appearing intranuclear inclusions and small basophilic lumpy cytoplasmic viral inclusions are also observed. The inclusion bodies are basically aggregates of CME nucleoproteins produced during viral replication. This is the slide showing intranuclear ouli inclusions of CMV, and this is showing intranuclear inclusions in the peritubular cells. This is IHC demonstration of CMV antigens, and this is the visualization of CMV virions in EM. For diagnosis, testing based on the type of disease. For a viral syndrome, the CMV viral load and the presence of syndromic features implies viral syndrome. And for the diagnosis of tissue invasive disease, the gold standard is to identify the presence of CMV inclusions or positive CMV specific IHC. Cultures, they may be contaminated by fluids, and blood PCR, they are used to guide therapy and to get a baseline. And one thing to note is that negative plasma or whole blood PCR does not exclude tissue invasive CMV disease. And for various target organs, specific tests for the same can be used. For pneumonitis, bowel or lung biopsy can be done, where IHC can also be done. In CNS, CSF can be tested for viral presence of virus, PCR. And in retinitis, ophthalmoscopy can be done, or serology, PCR testing from vitreous fluid can also be done. In GI, endoscopy and IHC from biopsy can be done. Coming to management, management comes in a setting of either asymptomatic viremia or CMV disease. Asymptomatic viremia is usually detected in the setting of preemptive therapy. And when there is routine screening of patients, we find that there is a CMV viremia or CMV DNA-emia, and in certain places they treat to decrease the progression to CMV syndrome and tissue invasive organ disease. But the threshold value for the initiation of treatment varies. Some say that at low levels, they just need to be monitored with probable alteration of immunosuppression, and in moderate to higher levels, they start on treatment. And in the presence of CMV disease, it has to be treated. Now, the initial step is the reduction of immunosuppression, because CMV happens in the state of a high net immunosuppressive state. So it can be either stopped or reduced. So the practice varies with center to center. At lower levels of DNA-emia or viremia, initially the antimetabolite can be reduced, and then monitor the CMV PCR at weekly intervals. And if viremia persists, antivirals can be started. At higher levels or severe disease, it is ideal to stop antimetabolites and start on antivirals. So for treatment, the first line treatment is intravenous ganciclovir or oral valganciclovir. Second line treatment is foscarnet and cidofovir. So in any case, the treatment should be continued till there is resolution of clinical symptoms and virological clearance below a threshold negative value. And it is ideal to continue treatment for at least 2 weeks. So in the presence of life-threatening illness like pneumonitis, meningoencephalitis, or in the presence of very high viral loads or moderate to severe gastrointestinal disease, it is preferable to use with parenteral ganciclovir, 5 mg per kg IV every 12 hours, and side effects of which are severe leukopenia, thrombocytopenia, diarrhea, and sometimes it can have issues with fertility also. In other situations, valganciclovir can be used, 900 milligram orally twice daily. Valganciclovir is an orally administered prodrug of ganciclovir. It is as effective as IV ganciclovir if GI absorption is not compromised, and it is well tolerated. Now, a short discussion of action and resistance. So this is the CMV virus, ganciclovir, which and cidofovir. They both lead to inhibition of the DNA polymerase. So when the molecule enters the cell, it needs activation by phosphorylation. And usually the DNTP sign is bound by DNTP, and it is required for the action of DNA polymerase and synthesis of CMV DNA. And phoscarnet acts by a separate mechanism where it binds to the pyrophosphate binding site of the DNA polymerase, and it inhibits this polymerase. Now, coming to resistance, ganciclovir is phosphorylated by UL97 kinase. So, when this gene is modified, it leads to ganciclovir or valganciclovir resistance. And in the presence of altered DNA polymerase, it leads to resistance to ganciclovir or valganciclovir and pseudofovir. And for phoscarnet, the resistance mechanism is different, and separate tests should be done for phoscarnet resistance. Now, the dosing of valganciclovir for a normal renal function, the induction dose is 900 milligram twice daily, and for maintenance or in the case of prevention, it is 900 milligram once daily. Coming to duration of therapy, the typical duration of therapy is 21 days, but can range from 14 to 28 days or longer. Once the symptoms and viremia are resolved, a secondary prophylaxis can be given, but the evidence for that is very weak. And if a patient on treatment develops leukopenia, the dose of antiviral therapy should be reduced only as a last resort. You need to look for other causes of leukopenia like MMF, cotrimoxazole, or a resistant CMV infection, and can also consider colony stimulating factor injections before reducing or stopping antiviral therapy, because reducing the dose of antivirals can promote resistance. Now, there are certain things which should be considered in viral load assays. The viral load values among CMV tests are not comparable. Patients should therefore be monitored using the same assay. The viral load values in most patients are 1 log higher in whole blood specimens compared to plasma. So the same specimen type should be used. The baseline viral load should be obtained the day that antiviral therapy is initiated and then should be monitored. The changes in viral load, to say there is a significant reduction, it should be 3 to 5-fold reduction. And the patient should be treated until the CMV load is negative and for a minimum of 2 weeks. There are certain predictors for recurrence, that is a persistently detectable CMV load following 2 weeks of therapy, and high baseline viral load and longer mean time to viral clearance. All these are predictors for a recurrence of CMV infection, and secondary prophylaxis can be considered in such patients. Short note on resistance. It happens when there is prolonged exposure to drug, usually more than 6 weeks. And the resistance to CM antiviral should be suspected when there is a rising viral load when the patient is on therapy, or when there is a rebound viral load, or when there is a persistently elevated viral load in the setting of adequate doses of antiviral therapy. So as told, when a resistance is suspected, genotypic assay for mutation in UL97 or UL54 can be done. And when there is mutation in UL97 or UL54, there is resistance to ganciclovir. And when there is mutation in UL54, there is resistance to phoscarnet and pseudofovir. Ganciclovir resistance conferred by UL54 mutation cannot be overcome by increase in dose of ganciclovir. So when there is a suspicion of drug resistance, decrease the immunosuppressive therapy if possible. And if there is severe CMV disease, you can add phoscarnet or switch to phoscarnet. And if there is no severe CMV disease, a full or high dose ganciclovir can be considered. Meanwhile, get genotypic analysis of UL97 and UL54. And if there is no mutation detected, continue full dose ganciclovir. And if there is only UL97 mutation noted, you have to look for sensitivity to ganciclovir. And if it is only low level resistance, then high dose ganciclovir can be continued. And if it is high level ganciclovir resistant, then shift to phoscarnet. And in the presence of UL54 and UL97 mutation, before continuing phoscarnet, it is ideal to look for phoscarnet or mutation. And if there is no evidence of such mutation, foscarnet can be continued. And if there is a mutation in foscarnet, then pseudofovir has to be continued. And despite all this, if the patient is not responding, can shift to non-standard or experimental therapy. Now, foscarnet, as said, is active against CMV with UL97 and UL54 mutations. It is highly nephrotoxic, and before giving this drug, hydration and close monitoring of electrolytes renal function is required. Pseudofovir is also highly nephrotoxic. It is active against CMV with UL97 mutation, but not against CMV with UL54 mutation. And it is also nephrotoxic. There is risk of AKI, and hydration and use of probenecid should be considered. Maribavir is a new drug. It is an oral drug. It inhibits UL97 phosphotransferase. It's a separate mechanism. So in the presence of other mutations, this will function. The dose is 400 milligram orally twice daily. It cannot be co-administered with other drugs. There is no bone marrow and kidney toxicity. It has interaction with CNI and mTOR inhibitors. And while on therapy, resistance to maribavir has also been reported, but this drug is not widely available. Letermovir is no longer recommended. It can be used as salvage therapy. And when all other measures fail, further reduction in immunosuppression can be considered or switch to mTOR therapy. Leflunomide artesunate has also been found to have anti-CMV effects. And anti-CMV immunoglobulins or IV immunoglobulins can also be considered in life-threatening situation. Short note on prevention of CMV after transplantation. There are two strategies. One is a prophylaxis and one is preemptive therapy. So prophylaxis can be a universal prophylaxis or specific prophylaxis. Specific prophylaxis when it is given for high-risk patients, where such as D plus R minus, and where ATG was used for induction. Prophylaxis, and then it is usually given for 3 to 6 months post-transplantation. In preemptive therapy, the CMV levels are monitored, and if it starts rising, then or it is detected, then need to start on treatment. A short comparison on preemptive and prophylactic therapy. The advantages of preemptive strategies: there is less drug toxicity, there is lower incidence of late CMV disease, and there is exposure to CMV virus, and it may lead to low-level exposure and immunogenicity. And advantages of prophylactic strategy is there is a reliable suppression of CMV replication. There is avoidance of the indirect effects like triggering rejection and other opportunistic infections. The risk of preemptive strategy is non-adherence and potential high risk for indirect CMV effects. And the risk of prophylactic strategy is drug toxicity, late CMV disease, and development of resistance. There are certain studies which compared valgan circular prophylaxis and universal and preemptive prophylaxis. So the conclusion was the preemptive therapy showed a higher incidence of CMV infection, CMV disease, and recurrence of infection. And valgan circular prophylaxis protects against CMV infection and may enhance survival in elderly people with cardiovascular disease. And the efficacy of 200 days of valgan circular in high-risk patients are also studied. This is done by Humer et al., already also known as the IMPACT study, where valgan circular prophylaxis are given for 200 versus 100 days. The conclusion was, compared to the 100-day group, the 200-day group depicted a significant lower percentage of patients developing confirmed CMV disease up to 1 year post-transplant. And the confirmed CMV viremia at 1 year was also lesser in the 200-day group. Another study compared low-dose valgan soclovir, and they found that the low-dose valgan soclovir for CMV prevention following kidney transplant is safer, more effective, and less expensive than the standard dose. Now, with that, I conclude my talk. And regarding the first MCQ, which of the following statements regarding prevention of CMV infection and disease is false? The false statement is that full dose of ganciclovir and valganciclovir should be administered to have the maximum effect with respect to your renal function. For using these drugs, adequate dose modification has to be followed. Summarizing, CMV infection can be primary infection, reactivation, or a superinfection. In most of the patients, it stays as a latent infection, and in the presence of immunosuppression or any immunosuppression, it leads to viremia. And in severe cases, it can lead to CMV disease when there is end organ involvement. And the most common form is GI involvement. And diagnosis is based on clinical history, clinical presentation, laboratory data, predominantly PCR and histopathological examination. PCR tests are widely variable, and so the same test during the same laboratory and with either blood or plasma should be used for monitoring the patient. Negative PCR does not exclude tissue-invasive CMV disease. And in severe illnesses, to start treatment with IV ganciclovir. In mild to moderate illness, can treat with oral ganciclovir. And considering universal prophylaxis and preemptive therapy, the usual practice is to give universal prophylaxis for 100 to 200 days post-transplant. And when resistance is suspected, ideal to go for foscarnet, and if possible, to do a resistance assay. Thank you.
Thank you.